Hello, I'm Richard Westerby, and welcome to IVF Daddies podcast. And today we have Dr. Paul Brezina, who joins us from the Fertility Associates Memphis. Hello.
Thank you for having me on today. It's a pleasure to be here.
So today, one of the topics I want to talk to you about is fertility around cancer. Obviously, a topic that is tough for many people, but I want to really talk to you about what do we do in situations where a patient comes to us and they say, hey, this is where I'm at. What can I do?
When people get a cancer diagnosis, what I hear from people, what it seems like they're going through is, why is this me? What am I dealing with? How do I move forward? And in addition to all of that, now there's this concern about fertility, and it's a whole new set of problems that are being thrust at them, and on top of compounded the fact that they're fighting for their life with this disease. And so I feel it's our job to medically advocate for them and fight for every chance we can to preserve that fertility. And also be a resource for them emotionally, because this is a really tough time, and, validate that it's normal and actually appropriate that they would be thinking about this during this time.
Okay. So somebody's come to you, say it's a woman that has come to you for XYZ cancer. What happens for her in that situation?
So I think it depends on what particular cancer it is. In our center in Memphis, we have a long history of dealing with cancer patients. And a large part of that is St. Jude. So we do all the fertility preservation for male and female cancer patients at St. Jude and have for the last decade or so. In addition, just being in a metro area, you have breast cancer, Hodgkin's lymphoma, all these things that can happen to young men and women. And I think that the timelines and how you deal with those different things varies depending on the type of cancer. A lot of it's going to depend on when do we need to start chemo? When do we need to start radiation? And if there's some flexibility, like with breast cancer a lot of times, then we might try to optimize the timing of the cycle to start. In other cases, we just don't have that time and we're just going to go. So I think we try to have a tailored and customized approach to everybody.
So if you have the time, what does that mean?
From a reproductive endocrinology point of view, you have at the beginning of when you first start to recruit eggs, and this is really more geared toward women than men, because men, you can just say, okay, we're going to get a sperm sample, we're going to freeze it. And that could be kind of pretty much whatever. With women, it's a little bit more nuanced. And yes, you can start the stimulation at any point during the cycle, but all things being, the cycle is designed to recruit eggs at the very beginning of the cycle, right after the menstrual period. And so if we're able to time it, if we're able to get 2 weeks, 3 weeks to get to that beginning part, we tend to see better results than if we start it after they've already got.
Right. Ideal situation, they've come to you, they said, I've had this diagnosis.
Right.
And you say, okay, well, what cancer is it? What is the diagnosis?
Right.
And then that informs how you're going to then proceed with treatment.
This is a village approach. This is not just me making a unilateral decision or even our clinic making a unilateral decision. We're calling the oncologist, we're calling the breast surgeon, we're calling whoever, and we're making a combined decision, a collaborative decision to make sure that we're maximizing the safety point of view for the patient, but also balancing that with getting the best yield we can for fertility preservation.
Why do we even need to do that when somebody has cancer?
Well, if you think about what chemotherapy agents are, right? They're agents that are designed to disrupt dividing DNA. That's what those agents are. And the more powerful those agents, the better they are at disrupting those DNA. Women in particular are born with all of the eggs they're going to have. And they haven't finished those divisions. And we really worry that if you throw something that is designed to be deleterious to dividing DNA, and you throw it on something that's sitting there, and then you ask that later to divide, we really worry that it might not divide as well. And that's what we see in the data. So we know that we're going to have a decrease in fertility after chemotherapy. We know we're going to see it for a long, long time. Even if we have returned to normal menstrual cycles, we still are going to see a deleterious effect from that. And it's because we've damaged the eggs that are sitting there since the person was born.
The chemotherapy itself damages the eggs to the point where it could be that they don't.
I think that's a really important point. That could be. We can't guarantee that they wouldn't be able to have a pregnancy in the future. We can't guarantee that they could or couldn't. What we're trying to do is fight for every percentage point we can. we're fighting for inches. So if we can get a cohort of eggs that are taken out before that chemo and they get pregnant later on their own, fantastic. That is awesome. But at least they had this redundancy if that didn't.
Giving them optionality.
Exactly.
To potentially have something in case they don't have.
At the end of the day, categorically increasing their lifetime chance.
And so what's the difference between that and men?
In men, it's frankly a little bit more forgiving. And that's because you're constantly making new sperm all the time. Now you're still having DNA damage to the apparatus that's making sperm. And that could have a long-term effect, and you can make the sperm that you make in the future, it could take a while to get back to a normal count, or it may never get quite back to a normal count. But the effect is not as profound as what we see.
Because they have the eggs in their system
the eggs
already.
are physically there. The sperm that somebody's going to use in the future hasn't been made yet. It's going to be made 70 days before they use it.
So then a question, actually. So a friend of mine recently went through testicular cancer,
Yep.
had one testicle removed,
Right.
but has one left. Does that have an impact on the sperm?
You know, it depends. It depends on what they did. If they just did a surgical extraction of that one testicle, it was localized and they didn't have to use chemotherapy or any like strong, chemotherapy agents, no radiation, we really wouldn't think that that would matter. We've seen a number of people where that has happened and, they get a sperm to cryopreserve sperm just to make sure. But at the end of the day, they didn't need it. Now, if you start adding chemotherapy, you start adding radiation, that can actually do damage to the actual testicle. And that's a different quantity.
Then you mentioned the fact that obviously somebody's come in with a diagnosis and you see what you can do. And if you can push the woman's start of the IVF process to the beginning of when her natural cycle would be. What if you don't have that luxury of time and the doctors are like, we need you in, we need to get this now?
We'll still push them and try to get as many eggs as we can. But if you think about kind of the way the cycle works in women, in the midpoint, they ovulate, right? And then it makes progesterone. And it's just a little suppressive to try to push out eggs while you're making progesterone in that second half of the cycle. You can do it. You can push through it. It's just, if you don't have the time, you don't have the time. I mean, some eggs are going to be better than no eggs. And if you've got particularly situations like Hodgkin's lymphoma or something where it's rapidly expanding, you're going to want to just go.
When you are sitting there and you are emotionally in a situation that isn't great, does that have an impact on the eggs and the sperm that you're going to have?
I don't know. Intuitively, you would think, yeah, that would. And we do see that the eggs that we get from people going through these treatments aren't quite as good of quality sometimes as they would be if they were not going, but they're being stressed with, how much of that is emotion? How much of that is the fact that they're going through this, assault on their body with the cancer? And how many inflammatory markers do they have? And, that they're making right there. And so I think that we can say that the stress of the situation is something that's a challenge, whether or not that's from emotional stress or from the physical stress of their body being assaulted by this cancer. I think it's hard to tease apart.
Because to me, logically, if I think about what your body is doing, your body is fighting to survive.
Correct.
Not fighting to procreate.
That is exactly right. So you have to overcome with our, we're getting stimulation meds to try to push that system as hard as it wants to go. But you're right. The brain's not on board with, hey, let's go do this.
But say, for example, I've heard of breast cancers that are hormone reactive.
Correct.
And breast cancers that are not.
Right.
How does that work?
Breast cancer always came from breast cells at its core, right? And all breast cells were at one time estrogen receptor or progesterone receptor positive. So if they've kind of like devolved away and they don't have those receptors, which is a mark of a little bit more of aggressive cancer, it's really difficult to prove that there's not populations within that still have some of that reactivity. Does that make sense?
I think you've lost me.
The point is, I think that most breast cancers, even if you test them, you take a biopsy from them and you say they're receptor negative, because they came from receptor positive tissue initially, there's portions of that still retain some of that positivity.
So that means that if you've had breast cancer, there is, and they say, no, it's fine. You can still take the medications or the estrogen or
we don't believe it.
You don't believe it completely because you still think that they could have an effect.
It could have an effect. So what we'll do is we'll use medications to decrease the systemic estrogen level while we're stimulating the ovaries.
Right.
That gives us a little bit of a downside on the number of eggs we get because we're giving a agent that's decreasing the ability to make estrogen. And that's really critical for maturing these eggs. So it's kind of this constant balance where how can we maximize the chance of getting quality eggs that this person can use in the future with how can we not hurt this person anymore during this time?
If you have, say, ovarian cancer, is that on both ovaries or is it on one? Can you still use one, not the other?
So I think all of those sorts of things become very case by case. It's going to be typical that if you have ovarian cancer on one side, we're going to take out that ovary and then make sure that you're kind of cancer free, then use the other ovary. To my knowledge, we were the first place in the country to report doing IVF on a ovary that actually had active cancer. And we reported that maybe 4 or 5 years ago, but it was a case where a young woman had a ovary that was taken out for cancer. We waited a couple of years and they redeveloped it in the other ovary and it spread to the other ovary. And we stimulated it through that period, got eggs, and then took out that ovary an hour after the treatment.
Right.
How do you know that you're not going to spread that cancer? And so it really requires a lot of specialized and very circumstantial risk benefit. Are you able to even describe all those risks? And probably not. But you're talking about somebody's future fertility, which is a really profound and core thing for folks, And so I think that it's okay to take some risk as long as everybody's on the same page and everybody's dialed into, we're all doing our best here.
Yeah. And it comes back to that team effort of you, the oncologist,
huge team effort
involved in the actual cancer.
Right.
So then a question, if say, for example, you have a hysterectomy, can you still keep your ovaries? And
absolutely. Yeah. So just because you've had a hysterectomy doesn't necessarily mean that they have to take out the ovaries. Now, what's a little bit complicated with that is that when they take out the uterus, part of the blood supply for the ovaries comes off the uterus. So you've compromised the ovaries a little bit just by the hysterectomy. Also, if there's any concern about the cancer in the uterus having spread to the ovaries, that's a separate concern as well. So how long are you going to keep the ovaries? Is that a concern? Are we doing this just in the short term to try to get eggs and then pull them out? How can you prove that you wouldn't be pulling cancer cells out during that egg extraction that could be reintroduced into somebody else later? And then you have a whole nother risk from a gestational carrier point of view. So that it becomes where it becomes quite nuanced. And how do you define those risks? A lot of times in those cases, when we've done something like that, we'll really only be okay with family members being the gestational carrier, because that's a risk that we really feel is hard to put on somebody else. And it's hard to demonstrate that we've really explained that risk.
That's a really valid point. I'd never thought about that. When you're at the front end of this, you're dealing with somebody who's going through, to your point, fighting for their life. Are they necessarily making those rational decisions? Not.
Yeah.
And we have to be potentially the bearer of the news to say, this is what we're going to do. This is all we can do.
Right. We can't
do anything.
Yep. And then you compound that with, financial stresses that go along with it. Have a number of people you talk to them, they're just like, I can't do that. And, we're just counting these cycles basically to our cost, because we're doing this to try to help people, right? I mean, this is part of what we do. We can just be good citizens within our community. We have a policy where if somebody has cancer and they come see, we'll see them within 48 hours. Like we could be booked out 3 months, but we'll see them within 48 hours. We see it as just sort of a thing that, is incumbent upon us as a practice within the Memphis community to offer.
It's just the right thing to do.
It's just the right thing to do. It doesn't mean that we can always make it perfect.
We can't make it work. We can promise that we're going to give you the best shot possible.
Exactly.
When somebody's going through an egg donation and they are injecting medications, I regularly get asked the question of, this may give me cancer. Can you talk to that?
Through college, both OBGYN, reproductive endocrinology, and even gynecologic oncology, all sort of outline that we don't think that this causes cancer. Now, you're throwing a bunch of, let's just say a woman without cancer is going through IVF. It's likely that you would be able to demonstrate that there's a higher rate of breast cancer diagnosed during that cycle. But that's very different than saying it caused it. Because what you're doing is you're taking a hormone receptive cancer and you're throwing a ton of hormones at it, making it get bigger, then all of a sudden you see it. But that's a very different entity than saying it caused it.
In effect, what you're saying is you had it, we just made it grow so that we could then see it.
Right.
We didn't give it to you.
Correct. Because if you say, okay, there's an increase in breast cancer diagnosed during IVF cycles, I don't think it's reasonable to say that that happened in the 10 to 12 days that you were giving those meds.
So then if you're an egg donor who's done it 6 times.
So I think that the other thing to keep in mind here is that we're using data that we have. You know, this field, the first IVF baby was born in 79? On a large scale, IVF's been happening for 20 years. Not a long time. We don't have a population of people in their 70s and 80s that have gone through 6 cycles of IVF. So I think the other caveat that I'm going to throw out there is that I'm not so confident in what we know now that we can't find something else new in the future. So I think that what we can comment on is that we don't think that this appears to be a problem. There's not evidence right now that this appears to be a problem. That said, I think that it's kind of foolish for us to think that we couldn't have problems with anything we do in medicine that we haven't followed out for a long time. And I think unintended consequences is something we should always acknowledge.
And I think that is something that within the IVF sphere, everybody's always thinking about. It's like,
Yes.
we don't know
Right.
10 years down the line what's going to happen, but we're doing the best that we can now with the data we've got now.
As straightforward as we can with what we know.
Yeah.
And
we're giving you the best chance of having a family that we can do.
I think that's all of medicine.
Yeah.
How do you know what these stem cell therapies are going to do to people? How do you know what immunologic therapies are going to do to people? How do we know? What the COVID vaccine is going to do? Like, you don't know, but you do your best and you make the best weighted decision you can going forward with every medical decision.
So I think that's really valid point. So thank you very much.
It was a pleasure. Thank you for having me.